Assalamualaikum and a very good morning to everyone. Welcome to today's edition of Breakfast at UMHealth, and I'm pleased to say that our session and its topics today are in conjunction with the ongoing ICU Rehab Week program, aptly themed ICU Rehab Move It. The program is jointly organized by the Department of Anesthesiology and the Department of Rehabilitation Medicine. The program is spurred by the recognition that ICU patients often continue to suffer impairments in physical, cognitive, and mental health way after their discharge from the unit. So there is therefore a big need to address these impairments early while the patients are still in the ICU if we are to see better post-discharge quality of life outcome among these patients. In this regard, to help us better understand what rehabilitation medicine could offer to our ICU practice, we are grateful to have with us today two rehabilitation physicians who will share their perspectives on, firstly, ICU rehabilitation as a whole, and later in the second topic, a more specific overview of the issue of ICU delirium. So it is now a great pleasure for me to introduce our first speaker, Dr. Shivani Rajasegaran. Dr. Shivani has been a rehabilitation medicine physician for the past 8 years. She started her specialist career in Hospital Sultan Ismail Johor Bahru, and she is now with Hospital Raja Permaisuri Bainun Ipoh. She has just completed her training in ICU rehabilitation in the East Kent University Hospital, UK, just a few months ago. And I know that since coming back, she's been engaging with my fellow intensivist colleagues in Ipoh, keen to share the new insights gained in the UK. So let's hear from Dr. Shivani, her views and ideas on ICU rehabilitation.
Thank you very much, Prof. Okay, let's get to it. I'm very honored to be invited to speak to everyone today. Thank you for inviting me to the UM team. I'm presenting on ICU rehabilitation, basically just a gist of it, so that it can flow well into my colleague's talk on ICU delirium. Right, so what I'm planning to address during my talk today is how early do we start rehab in the ICU? How early is early? Who will actually benefit from rehab in the ICU? What are the precautions? So this is what most of us are pretty worried about, when we can move the patients and when we can't. And what services can we actually offer in the ICU? And what is our main goal? I will digress a little bit so that we have a better understanding of what happens when, especially the actions that we take in the ICU and how it affects the patients. So how early is early? Right, so there are a few definitions available. So basically what the European Association of Critical Care defines early is when the patient is fairly stable physiologically, although they are still on ventilators and vasopressors. The NICE guidelines comes up with a few days. So they've given the number of within 4 days where you need to establish rehab goals, and earlier if less than 4 days. So this is a bit vague. So what we have decided in Ipoh and from my ICU rehab team is after day 3, if patient is admitted in the ICU and they are ventilated, you can already start referring to rehab. And if they are not ventilated, after day 7 in the ICU. So we chose this date because this is when the biochemical changes start to take place, when ICU acquired weakness actually starts. So very early, and this actually applies to almost all patients. So please do refer them to us. And I must remind you that ICU rehab is not only in the ICU, we do follow patients up later as well. So this is kind of the flow of how we see patients. We see them during the critical care. Before they are discharged from the critical care, please do let us know so that we know where they are going, either home or ward, and we can continue the rehab there as well. As my rehab colleagues know, we do follow them up right up to the community. And we would like to see them 2 to 3 months after discharge in the post-ICU clinic. So if you do not already have a post-ICU clinic established, I would encourage you to have one to see and try to address the issues of post-intensive care syndrome for these patients. And I've put a star here as well. As you can see, the family is very, very important. Family involvement, I would like to say, starts from the very beginning as well. I do know there are some restrictions for COVID in the ICU still, but if you do allow some family members in, we would like to get them engaged with the patient in the ICU. They need to understand why sometimes the patients take very long to recover and how ill they actually were, so that there is some understanding between the family members and the patients. Right, so who will benefit? I would like to say everybody, but my team would probably kill me. But generally, the patients who are coming for sepsis, yeah, so they're very prone for ICU-acquired weakness. Typically, those who have neurological disorders, that's our main bread and butter in rehab. Even if they're not referred in the ICU, we would see them in the ward. Patients with brain injury, stroke, spinal cord injury, and neurodegenerative orders, we would really appreciate if you could refer them to us in the ICU itself. I do get a lot of referrals for prolonged ventilation and difficulty weaning. This is an issue in the ICU, but not the only reason to refer to the rehab. And if they do have premorbid disability, that would be nice that if we could see them in the ICU so we could address their issues and we don't miss them while they're in the ward. So yeah, I would like to highlight this again. We don't just focus on respiratory rehab in the ICU. So patients who require a lot of chest physiotherapy, a lot of secretion management, yeah, we can do that, but that's not the only thing we do. So what else do we do? Right. So our aim in early rehab. So the main aim actually is preventing post-intensive care syndrome. So this post-intensive care syndrome is not just the physical aspect of the patient where they develop weakness, weakness of the musculoskeletal system, their diaphragm and things like that. It's a lot of cognitive and psychological problems that they have way beyond the ICU. So we need to sort of tackle these things early so that they don't have a lot of post-traumatic stress disorder, a lot of anxieties later on. Now, the term long COVID has been popularized because of COVID. In the UK, post-intensive care syndrome clinics have been going on for the past 10 years. So when COVID came along and they had symptoms of patients with symptoms of long COVID, they sort of incorporated them into the post-intensive care clinics. And they were able to manage them and they were not really neglected. For us here, it's gone the other way around. We sort of realized that a lot of these patients who were in ICU for COVID had a lot of problems later on. And so we've already started the post-COVID clinics nationwide. And I do feel that we need to start in post-intensive care clinics as well, long after COVID goes away. And we need to address these issues and not neglect this group of patients. Just as I said, it's not just having a ICU-acquired weakness with the patient. We need to address the trauma that the family goes through as well. So early rehab does affect the quality of life of ICU survivors. Okay, I do get a lot of questions on how we are going to mobilize these patients. And I've had my fair share of dislodging lines and, monitors almost falling down and ventilators being very shaky. Yeah, so you learn through experience a lot. I've dislodged a patient's mucus plug and see him breathless there, almost collapse before my eyes. Yeah. There are a lot of things that can happen when you're trying to mobilize patients. Things can go wrong quite easily, but there are a lot of monitors around to help you, to let you know when patients are actually going to go in distress and if the oxygen saturations are dropping. So don't worry too much. Always discuss with your intensivist before you want to mobilize patients or try to get them out of the bed. Your nurses are a great help. They do sort of have an idea whether this patient can comply with your therapy today or not. So do have a lot of communication with your patient, with your staff before you try to mobilize the patient out. All right, so we already have these protocols in place. So we have this move screening where you can actually still move patients out of the bed even when they are on things like vasopressors. You just have to make sure that they're not on very high doses and they haven't recently increased them. You don't have to put them on the standing frame, just sitting them up on the bed should be fine. Like I said, they already have monitors in place, so you can monitor if they're going into any abnormal rhythms and if the SpO2 is dropping. So don't worry too much about mobilizing patients because you can't see if they are going into distress. You can see that they already have this implementation of level 1, 2, 3, and 4 mobilization of the patients. So what rehab does is to give even more than this. So if you're already practicing these protocols, good for you. Let rehab come in and do even more for you. Okay, so sitting patients up in the bed for level 1 to 3, it's not just about sitting them up. You have to provide them with activities that they can engage in. And like I said, post-intensive care syndrome has a lot of cognitive and psychological effects. If you sit the patient up in the ICU and you don't provide them with something to do, some distraction, they won't be able to sit very long and they won't be able to engage themselves cognitively. So you can see we have this patient here that my nurses set up. They even use boxes here to support the back because she didn't have very good truncal balance. We've put the TV here and we tried very hard to get a reception with the aerial sitting right here in the window, you can see. So yeah, you have to be a bit of a ninja in the ICU, but it can be done. Right, so getting patients to perform their ADL. I would encourage this a lot. You can see in the ICU here in Ipoh, we have very large windows. So, and we let the sun in. So we get the patients orientated very well to daylight. And this will help with ICU delirium, with what my colleague Pek will be speaking about later. Trying to get them to do very simple things, brushing their teeth in the morning, just getting them to wipe their face, doing basic grooming, combing their hair, helps them a lot to get them orientated to what time of the day it is and getting them to do their basic functions again. And it has to be something that, and you'll be surprised how you actually get them cognitively engaged, see their coordination, do a lot of functions that actually engage them so that they get to a normal environment as possible. So you don't have to be very skilled to do this. You just have to be quite creative. Sometimes positioning items on the bed, trying to get the level of the TV and the bed, all requires a bit of fine tuning. But once you do it every day, it's actually quite easy. Right. So this is a patient we got propelling the wheelchair. Yeah, so I had to tell Fong and Siti in Ipoh that rehab team, we don't like patients to just sit down and do nothing. We like to torture them a bit. So I got this guy to propel his own wheelchair. As you can see here, we required 2 staff actually to mobilize this patient out of the ICU, one to hold the ventilator and one to hold the oxygen tank. We do have some ventilators that have oxygen port that you can place the oxygen in. So equipment is quite important. If you can have equipment that reduces the number of staff when you mobilize patient, that is good. Having a good communication, because you have to plan these outings with the patients and you have to make sure that you have enough staff available in the ICU and staff to take the patient out as well. And if possible, do please involve the family. I would like to see family involvement in the ICU a lot, and I think I've repeated this a lot as well. This is us taking the patient out into our lovely garden in Ipoh. I'm very proud to say that Ipoh, we have a garden within the hospital. So we've taken the patients out with ventilators. The patient was quite delirious in the ICU, and once we took him out, the delirium was much less. This is my dream, to take most of the patients out so that they can listen to the birds, enjoy the trees, instead of listening to the monitors and alarms goes off. But you can see that the staff enjoyed it quite well. They enjoyed taking the patient out. Okay, so post-intensive care syndrome. What I would like to stress here is that it includes not only the patient, but the family as well. So we do have family members coming in with the patients in the post-intensive care clinic with a lot of anxiety and post-traumatic stress disorder. And you can see that the physical aspect of problems that the patient has with mobility is just a portion of post-intensive care syndrome. They do have a lot of psychological and cognitive problems, and this carries on way beyond the ICU setting and into community as well. So let's move on to something a bit different. Right. Let me just enlighten you about the WHO definition of torture. And I'll tell you why I'm telling you this a bit later. So the definition of physical torture includes beating, electric shocks, stretching, suspension, submersion, suffocation, burns, rape, and sexual assault. Psychological forms of torture, this is based on the definition, WHO, okay, is isolation, sleep deprivation, sensory deprivation, pharmacological torture, threats, humiliation, mock executions, mock amputations, and witnessing the torture of others. Right, so now let's move on to the ICU. Right, so sometimes uncomfortable positioning by us restraining or doing prolonged stretching on the patient can be perceived as torture. I do have some patients in the post-ICU clinic having a lot of anxiety about wearing the mask now during COVID, because they have flashbacks of the BiPAP and CPAP mask on their face and, you know, having that sensation of suffocation. Yeah, so most of the patients in the post-intensive care clinic never forget having the Flexi Seal inserted. It's good. They do have some feeling of sexual violation. Counseling the patient properly before inserting the Flexi Seal is important, because they do remember this way after the ICU, and they do have a lot of anxiety and PTSD after that. The cold environment. So Malaysians, yeah, we some of us just can't take the cold, myself included. So please be aware if the patients are feeling very cold in the ICU, do pile on the blankets if needed. Isolation, sometimes this can't be helped, but we try to, getting the patients engaged with activity does reduce that isolation. Sensory deprivation, sleep deprivation, sometimes these are unavoidable in the ICU, I must say, but we must try to minimize this deprivation as much as possible, because it does have some effect to the patient later. I do have patients recently with COVID who have a lot of vivid dreams about being abducted by aliens because of the PPE that we wear, and this is what they perceive. So sometimes the drugs that we use for sedation, and sometimes the drugs that we use to for pharmacological restraint instead of physical restraint, do cause a lot of problems to the patient later, as my colleague will describe later in ICU delirium. Threats. So patients sometimes perceive your actions, your tone of voice, your touch. They do perceive this even if they're under a lot of sedation, and they do sort of remember this. So try to be very gentle with the patients in the ICU. You have to be aware of the things that you're saying and doing in the ICU when you're around patients, even though they are quite sedated, because they do remember these things. Humiliation, yeah, so a lot of patients sometimes do feel that they were quite exposed in the ICU, and they've given this feedback in the clinic. So try to minimize their exposure, do counsel them, like I said again, when you're doing any procedures like inserting the catheter or the Flexi Seal. Loss of liberty, yeah, they do feel that they don't have any freedom of choice in the ICU. So this is quite frustrating for them. Sometimes when you are inserting the Ryle's tube, please do explain to them while you're doing it, while sometimes you have to restrain them, explain to them that they are trying to pull out their Ryle's tube, that's why you're restraining them. Be very gentle and keep talking to them. Mock executions, right? So WHO definition of torture. So patients do get affected sometimes when they see you resuscitating a patient nearby or doing CPR, and this causes a lot of anxiety to them because they feel sometimes they're probably going to be the next one in line. And when they are on a lot of sedation and a lot of drugs, they do perceive things differently. I do have patients saying that, I felt that the doctors were chopping up the next patient next to me, or playing a game I was like in a game show and the doctors were doing an experiment on me. So all these things is how they bizarrely perceive things in the ICU. Witnessing torture of others, yeah, they perceive sometimes that you're torturing other patients. Food and drink deprivation, sometimes we do have to fast them, just explain to them why. And sound torture, yeah, so I put the picture of the tap dripping here. So the beeping and alarm sounds can be quite distressing to patients. If possible, try to silence them whenever you can and reduce the noise, especially at night for patients so that they have good sleep. So post-intensive care syndrome, what I would like to stress here is what happens in the ICU doesn't always stay in the ICU. It does go beyond. So one of the clinical psychologists sort of explained it to me that the memories formed in the ICU are like boxes floating around. They're not really stored very well, and they can sort of prop up anytime. So we have patients sometimes driving, and then when they hear the horn sound, they suddenly have a flashback of what happened in the ICU, and they get a panic attack and a lot of anxiety. So these kind of things can crop up anytime, or sometimes when they hear a familiar sound, yeah, they can go into a panic attack. So I think having a lot of psychological support after the ICU is quite important as well. And I can go on and on about this, but let's move on. Right, so let's make the ICU a very fun place. Try to, the PICU is where we usually try to make it very colorful and have balloons and things like that. We managed to take one of our patients out of the ICU who was in for a long time. And all he wanted to do was see his dog. So he was very happy to see his dog the other day. Music therapy. So this is something I would like to implement as well. There is a prescription for music therapy in terms of volume, tempo, and how much of bursts of music you have for the patient. And I think it's something that it's nice to implement in the ICU. What they had in the UK was playing the patient's favorite songs. So even though sometimes it was heavy metal music, we would play bursts of heavy metal music to the patient so that they get something that they're familiar with within the ICU, to try to normalize the environment for them. So this is as far as I got with animal-assisted therapy. The PICU in Penang has a lovely garden outside, very accessible, and there were some cats loitering around. So we managed to get one patient to expose to a cat for a while. I don't know when we can bring other animals into the ICU. Let's see what we can do in the future. So how can we work together, right? So communication is key, and I can't stress this more, because having a good relationship with your intensivist, with your ICU team, with the nurses, because we do not have many therapists as of now, and I have a feeling this is going to be a problem for a long time. The patient to therapist ratio in the UK is actually 1 therapist to 2 patients, 1 occupational therapist to 10 patients, 1 speech therapist to 10 patients, and 1 clinical psychologist to 25 patients. So they have a very good allied health team in the ICU, always moving around, and the intensity of rehab is incredible. So the more hands we have, the better it is. Unfortunately, we don't have that kind of intensity in our KKM setting. So nurses have to take on the role. So I depend heavily on the nurses to try to carry out my rehab activities in the ward, actually. Equipment, if you have ventilators that are portable, monitors that are portable, that will really help us to take patients out and reduce the number of staff that we need to mobilize patients. Having things like hoists is a great help because transferring patients is an issue. Accessible environment. So Ipoh, we are quite, I'm fairly happy because a lot of the areas that I want to get to are quite accessible to wheelchair. We just need to plan their route. I would also like to incorporate things like animal-assisted therapy, music therapy, and art therapy. You can try to do that in your ICU as well. And please do include the patient's family in the rehab process and be creative. Yeah. So ultimately, just do it. If you have doubts, talk to your ICU team and just try it. The more you do, the more comfortable you will become. Right. So I have a marriage proposal. Right. So I would like to the rehab and the ICU team to collaborate. I suppose Fong and Siti and I are still in the honeymoon phase. So we are still working very well together. Let's see how it goes in about 10 years' time. Hopefully we are still happily married. So this is Ipoh, our lovely garden. This is the view from the ICU. And this is where I want to get my patients up and out. Hopefully we can achieve this much more in every other facility in KKM. Right, that's the end of my talk. Let's see, do we have any questions? Okay, we have a question from Chua. Are the members of your ICU inpatient? Yeah, so a lot of training for me to do. I still have a lot of ideas, and basically we only have one clinical psychologist in the whole hospital, and I sort of can't burden that poor clinical psychologist. But I do sort of refer patients that I can't handle to him. Most of the psychological support is done by our ICU team, the nurses, plus our rehab team as well. So because we are aware of some procedures that are done in the ICU and the patients don't understand why these things are done, we sort of sit down and explain to them what they went through in the ICU. And this helps them understand that what they went through might not be so traumatic and so harmful to them. And this includes the family as well. Is there a garden you can access at PPUM? Is there a garden, Prof?
Perhaps, yeah, I'll respond to that. Thank you, Prof. Tunku Sarah, for the question. We have taken our patients to the garden next to the KWKK, and we've even taken our patients to the garden next to Dato' Panglima Kinta Research Center. But that's quite, as you can see, quite a distance from where we are at level 2 of Menara Utama. Yesterday, we just had a discussion with Prof. Nazira about the plan to have a small garden within our ICU. But let's see how this could be planned for the next few years. Thank you. Okay, thanks, Shivani. That was very engaging, enlightening, and I must say, passionate. All right, a few strong messages there, and we'll comment on this at the end of the session. All right, music therapy, the psychological impact of physical restraint, for example, and you aptly ended your talk with the emphasis on good communication between the rehab team, ICU team, and also the family.
May I add something about physical restraint, Prof? In UK, physical restraint is almost banned. You have to get in a lot of patient advocates. It's a lengthy process to actually restrain a patient. And they use a lot of pharmacological restraint, which affects the ICU delirium a lot and impairs our rehab therapy. And I don't think physical restraint sometimes is a very bad thing. Mm-hmm. There has to be a balance. I do see our patients coming out of delirium quite quickly in our ICU setting because we don't use so much of pharmacological restraint. So yeah, not too bad.
Okay.
What we're doing is not too bad. Yeah.
Yeah. So we do have some mechanisms in place before you actually apply physical restraint, but it's all about enforcement, getting everybody to actually document it and contact the family. Right. So you mentioned about ICU delirium, and it's time to move on to the next speaker. So Dr. Pek Eu Way is a rehabilitation physician here in Universiti Malaya Medical Center. And like Dr. Shivani, Dr. Pek is also keen on intensive care rehabilitation. And he has been a regular feature in our ICU here in UMMC. His areas of interest within ICU rehabilitation include early mobilization, secretion management, and ICU delirium. So Dr. Pek will be sharing his insights on the topic of ICU delirium. So let's hear from him.
Hello, hi, good morning. Hi, thank you for the kind introduction. Thank you very much, Dr. Shivani, for making my talk so much more easier with such a nice introduction. Okay, all right. Okay, let's crack on. Okay, so my topic today is on addressing ICU delirium. Okay, just give me a moment. All right, I don't have any disclosures. So I'm just going to go straight on in regards to an article Dr. Josh Engel actually wrote about previously. Dr. Josh Engel is actually a very famous physician and a psychiatrist who came up with a biopsychosocial model which we use so often. And it is also an introduction or a segue to our ICF model right now that we use a lot, so much in rehabilitation. So what Dr. Engel, Josh Engel, actually did say that despite we do understand so much about the organicity of the brain problem, okay, we actually do not address so much in regards to delirium. So he actually go on to blatantly or brazenly, bluntly say that it is somehow that probably we physicians sometimes we are ill-equipped or it is our deficiencies in our education that we are not actually addressing this. And this was probably about 40 or 50 years ago. So probably he actually has a point in this because right now we are so good at like addressing other organic problems, the heart, liver, kidney, physiological and functional problems. But, we do need to know that the brain is also a very, very vital organ. And it's at times not addressed that well. So we talk about delirium so much, but we do not understand that much what is the definition. So according to the DSM, all right, just give me a moment. According to DSM-5, all right, basically as long as you have a disturbance of attention and awareness, acute onset in nature and fluctuating, with additional cognitive disturbances, it could be like, any of the cognitive domains, okay, such as memory, language, perceptance, which has been ruled out and not explained by other disorders, and usually due to medical conditions, intoxication, withdrawal, and multiple etiology. So this is the basically DSM-5. All of the criteria have to be met before one actually can diagnose a person to have delirium. So, so what happens if you don't actually, fulfill all the criteria? So nowadays, there is this thing called a subsyndromal delirium. So it means the delirium is present, but not necessarily fulfilling all the criteria. So, Dr. Wes Alley, okay, who is from the Vanderbilt University in US, he's actually one of the physicians who actually look into delirium a lot, especially ICU delirium. And what he did was that he tried to classify into a couple of subtypes of the motor, based on the motor features of the delirium. And he did come up with the hyperactive, the hypoactive, and the mixed. So hyperactive are the typical ones that you really see the patients really agitated, whereas we usually miss out on the hypoactive and the mixed because, hyperactive, the patient is like, quiet over there. They're not responding probably that much to communication, but if let's say if we do not actively screen the patient, we might miss it most of the time. And there's of course the mixed. So this paper was actually, Waters actually came out with this paper in 2008 to go on to show that why delirium is really important to be addressed. So because basically it takes about an onset of about 2 ± 2 days, okay, a duration once you have a delirium, it at least is about from anywhere between 2 to 6 days. Okay, and because of that, there is a higher risk of or an increased length of stay in ICU. All right, and delirium tends to persist even after discharge, 10%, increased hazard ratio, and definitely increased cost. So in his paper, actually, it's sort of like a narrative review, and he actually looked into some of the papers, and you can actually see again Dr. West Ali's paper, 2 of it, to actually go on to show that there was also higher mortality rate as well. Okay, and let's go on to the long-term cognitive impairments. This was a paper done in 2013 where about 800 people was enrolled with respiratory failure and shock, and they were assessed. And in 3 months and 12 months time, they were assessed with not a screening test, but a battery test. So this was actually quite, most likely quite stringent. And they found out that at 3 months, about 40% of the patients actually still had global cognition disorder akin to moderate TBI, and about 26% 2 standard deviations below normal population, which is akin to a mild Alzheimer. So Alzheimer's. So at 12 months, this figure actually reduced slightly to 34% and 24%. So actually, it's still quite significant. And so what are the what does the guideline say? So the Society of Critical Care Medicine came about and came up with a guideline in 2013. So basically, call it the PAD guideline just for short. So basically, to address pain, okay, agitation, sedation, and delirium. Okay, at least then almost there was the awareness in ICU and to actually to address and to manage it. Okay, so of course, those who are in the ICU, they will be very well versed with what sort of sedation assessment used. Basically, usually Richmond agitation sedation skills used. Okay, and on top of that, for delirium screening, usually a CAM ICU screening is done, which actually just takes less than a few minutes, less than 2 or 3 minutes. So on top of that, when it comes to screening, there is another screening tool which you can use, which is the ICDSC. So basically, what are the difference if you have these two scores? So basically, if you have an ICU CAM score, so it's more for CAM ICU, it's more for a snapshot of that period. For example, if the staff nurses actually was reviewing the patient, they actually perform a snapshot of that 8-hour shift, for example. Whereas the ICDSC takes on the whole 8 hours and then actually chart it. So the ICDSC also actually takes less than 5 minutes as well. So what is the difference that you would like to, what are the different pros and cons, and when would you like to use it? So my take is that according to this paper by Larson, if you're doing in a neurological population, neurosurgical population in a critical care setting, okay, the ICDSC is much more sensitive and specific. So you can actually go on with that, all right? And also they've got a very good ROC score as well. And yes, so this is the both sensitivity and specificity from this paper. It goes to show that the ICDSC, the ICDSC is actually more sensitive and specific by, because it takes on the whole 8 hours of the shift and you just chart it within that 5 minutes. Whereas CAM ICU is just a snapshot again. All right. All right. So they realized that delirium were found in no surprise 67% of the neurology ICU patients. Okay, and ICDSC is more sensitive and specific in neuro ICU. So later on, in about 2017 or 2018, these people who came up with the PAD guideline from SCCM came about with the PADIS guideline, and they finally started to address the issues with immobility and sleep disruption, which is quite important as well in terms of addressing ICU delirium. Okay, and so these are some of the few suggestions which actually have been recommended by the PADIS guideline. Okay, and of course this was when dexmedetomidine or Presidex was actually introduced for pre-extubation agitation. Okay, and early mobilization and sleep, such as protocolized sleep, with iPad, earplugs, dimmed light environment. These are all quite important as well to minimize the effect of delirium on patient. So again, Dr. West Ali. So he's actually really passionate and he came up with a lot of papers. And I think if there's any paper you would like to start reading up and to understand ICU delirium, this narrative review is the one, which is actually quite fairly recent. So it goes on to show that actually he made it in such a way that it's a flow chart or an algorithm to go about screening and to actually to find out what is the cause and how to tackle ICU delirium. So in question 1, you would see that how would you want to assess with CAM ICU and ICDSC. If there is delirium, then you actually could progress to there's this mnemonic they usually use, which is Dr. Dre, DRGRE. Yeah, Americans really like mnemonics a lot. So basically, it's disease remediation, drug removal, environmental improvement. We'll go about it later as well. And that is also in question 2. We have to look at what is the RAS score and is there any other hallucinations, delusions, anxiety, and whatnot. So if there is, then of course the question 3. 3.1 to 3.5 actually looks into what are the risk factor that actually cause. Does the patient actually have, prior psychiatric problem? Does the patient have any opioid dependence, home medication, or any alcohol withdrawal as well? And how to go about tackling it. Of course, in the flowchart as well to avoid benzodiazepines, okay, and consider antipsychotics, just consider or dexmedetomidine. And this is also another nice and simple flowchart as to how to go about the CAM delirium protocol, how to go about screening with the CAM ICU, and how to go about tackling the issues. Okay, so one of the medications that we are quite concerned of is any medication which acts centrally, especially benzodiazepine, opioids, anticholinergics. We know that sometimes, that it is unavoidable, but we try to minimize it. Even metoclopramide, then H2 blockers also might actually affect this as well. And environment-wise, from the, remember just now the mnemonics we were talking about, Dr. Dre, okay, is that you need to look into early mobilization, which I will explain why early mobilization is quite important. Sleep, hearing aid, whether, glasses, we need to look into this because sensory deprivation actually worsens delirium. Light, noises, these are the small things like what Dr. Shivani said and highlighted really well that actually can cause and worsen a person's delirium. So, of course, to look into what is the main cause. Was there any drug, iatrogenic drugs, or was there any hypoxemia, infection, new onset, sepsis? Usually, sometimes delirium could be the harbinger of a new problem in ICU as well. And of course, if you can, in the environment, sometimes as what Dr. Shivani did say that, in isolation room, if it's really unavoidable, the best is that if you could actually make the room as familiar as possible, decorate the room, introduce scents that the patient is actually very familiar with, such as like, like coffee smell, if the patient really likes coffee, or some sort of, whatever smell that you can put it in. His favorite music, doesn't matter if it's rock songs or, as classical as a Baroque song from Vivaldi, or, or to orientate the patient as well. And of course, to actually establish communication, which is one of the missing links that we tend to struggle with a lot. Imagine, that a lot of our patients are actually on tracheostomy, mechanically ventilated, ETT tube, endotracheal tube, and so on. So communication is a very, very big problem. So, so there are, of course, our therapists who can actually look into it, and one of it is our speech therapists who actually can look into AAD, which actually we can use low-tech and high-tech, and depending on the availability of the facility in the hospital. Okay, so which actually can use anything as much as like mouth, mouthing to gestures to picture boards and whatnot to actually bridge that gap. And these are some of the papers or the boards or the communication board that you actually can get it from ICUdelirium.org. Most of speech therapists actually have it, but ICUdelirium.org actually is a very resourceful webpage which they allow us for free to print this. And this is the communication board with, if the patient cannot point to a picture, you can actually point to an alphabet to form words so that we can understand them. So on top of that, we actually don't get our occupational therapists enough in ICU simply because, of course, we have lack of manpower as well. But in this systematic review by Kirsten Dimmer, there was this one paper, if you could actually look into, which is by Alvarez et al., where they actually started early occupational therapy cognitive training in more than 60-year-old patients who were not ventilated. And surprise, surprise, they did go to show that actually their FIM score, which is their FIM score, which is the, if I'm not mistaken, the functional independence FIM score. Basically, it is akin to an MBI score, it was actually much higher compared to those who did not receive intensive or cognitive therapy. All right. So a little bit of an update. I'm just going to breeze through really quickly. So what does the evidence say between propofol and dexmedetomidine? Apparently, this is quite a study, a recent study, if I'm not mistaken. It is in 2020, published in 2021. 13 centers, about 400 people are mechanically ventilated, light sedation, okay, with fentanyl. Of course, along the way, some of the patients require neuromuscular block, antipsychotics, and whatnot was not able to be avoided. They had a full ABCDE bundle. Too bad they don't have an F, which is the family. Okay, but the delirium-free days are almost the same for the first 14 days. Was 10 versus 10.8. And then second outcome was the ventilator-free days, pretty much almost the same. Death, pretty much almost the same, as well as the TICS, which is a telephone-based assessment of the cognitive ability of the patient through phone at 6 months' time, which is almost the same as well. So conclusion is that if you do really run out of dexmedetomidine and if you're in a critical care, you actually could use propofol. Okay, and on top of that, yeah, so this was the outcome of the TICS, which is a telephone interview of cognitive status, okay, which you don't see much of a difference between the propofol and the dexmedetomidine group. Okay. And we're just going to go a little bit in terms of COVID-19 because it was a pandemic. We really could not go without addressing it. And in this study as well, which involved Brenda Pan, who actually works quite closely with Dr. Wes Alley as well, they actually done a retrospective cohort, okay, during the peak of COVID-19 in 69 ICU centers from January to April 2020. And basically recruited patients more than 18 years old with very severe COVID. And they did notice that actually there was a severe restriction of visitation, so that there was not so much of family involvement. Early mobilization was really affected, and then there was a high usage of benzodiazepines simply because they actually ran out of dexmedetomidine and propofol. Okay, and in this paper as well, okay, if you could see, there was actually severe lacking of the visitation, as I've said. So this paper actually goes to show that if you look at the last box, which is the blue box down there, visitation from family and friends, actually it lowers, they notice that actually this lowers the risk of delirium. So this paper goes to show that, of course, the avoidance of benzodiazepine, yes, early mobilization probably, but most importantly also we need to actually involve family and friends as well to come in. Okay. All right, but of course, this study there are some drawbacks, and it's a retrospective study, lah. Okay, all right, and another a short update. Okay, in regards to this, this was actually a paper that came out in the Australian Critical Care Journal, which they actually sift through the Chinese database. So, and from there, they did notice that family participation, okay, and early mobilization had actually moderate evidence. So we usually think that that it is other causes addressing the root cause that actually could prevent delirium. But similarly important is that we actually have to look into family participation and also early mobilization, which actually has moderate evidence in preventing delirium. So let's actually broaden our scope and actually involve this to prevent further delirium. We probably have to look into these factors as well. So a little bit of, in summary, so this is, there's no basically benefits between typical and atypical antipsychotics, dexmedetomidine, statins and the ketamine, which was actually mentioned in the in that paper, in the previous paper, all right? And then decreasing sedation is important, which was actually recommended by the PAD guideline. Okay, keep it between RASS -1 to +1, unless the intensivists actually have a proper reason to actually keep the patient's sedation deep because of the ongoing medical problem or surgical problem. And it has to be bundled, okay, the ABCDEF, with the analgesia first, controlling pain, and of course, not always to involve family member, early mobilization, and sleep improvement as well. All right, so I wish I had more videos to and testimony to actually go to show, but unfortunately I couldn't get one. We actually had patients who actually had delirium and actually came back to the clinic to say that they actually had PTSD, intrusion thoughts, the typical DSM fulfilling criteria as well. but they actually did understand it and actually went away eventually. Yeah, but I'm very, very thankful before I go and before I take up any questions that I would like to thank Prof. Nazira in actually espousing ICU rehabilitation, Prof. Azim as well from our ICU, Prof. Rafida as well, in actually understanding so much about the importance of ICU rehabilitation, allowing us to come in to work, to cooperate and work with them so well. Thank you very much. If there's any questions later on, you can actually email me, but I can take a couple of questions right now if you all have. Let me look into the...
Thank you, Pek. Another engaging and passionate talk by our rehabilitation physician colleague. You highlighted a few important points that we should approach this as a bundle with a lot of emphasis on early mobilization, communication, and visitation from family and friends, something that we've missed quite dearly during this COVID pandemic period and up to a certain extent now. We welcome questions and comments. Another point highlighted by Shivani just now is the importance of post-ICU clinic. This is something that we've been discussing. And maybe, Shivani, you would like to share some of your experience with the post-intensive care syndrome clinic in the UK. You are muted, Shivani.
Okay, can you hear me?
Yes.
Right, great. The post-ICU clinic that they conducted, like I said, it's been going on for the past 10 years. It's basically something like a group clinic, something like what we already have now with the post-COVID clinic. We have like a few sessions with physiotherapists, occupational therapists, dietitian, pharmacists, basically just talking out what symptoms the patient has. The physical aspect, the weakness is not really an issue. Most of the times during the post-intensive care clinic, you're dealing with the post-traumatic stress disorder, the psychological issues that they have, the anxiety of trying to move forward. We have, you must remember that the family, you have to get the family into this clinic as well, because the family has gone through a very traumatizing experience. They almost lost their loved ones. So they can be a bit of a problem at home as well. They sort of don't let the patients do a lot of things and keeping them quite dependent. So there are a lot of issues in the post-intensive care clinic. You will learn along the way, but the key is to just start it. And then if you need any help, of course, I can sort of step in. It's not really medical problems you're dealing with. Like I said, it's a lot of psychological issues. If you do have a clinical psychologist at hand, that would really help. Keeping them on a regular rehab program with outpatient physiotherapy and occupational therapy is important. But a lot of them, because they were still, over the past 2 years, they couldn't come out of their homes. They used a lot of YouTube videos to do home exercises. They had a lot of online support groups from, you can go to the Thomas and Guy's Hospital website. They have a lot of videos on ICU survivors. So we do have a lot of ICU survivor support group networks and things available online for them. So we can access them if they're quite remote as well. But I think just starting off the post-ICU clinic is important. Yeah, how you do it, yeah, you have to sort of fit them in. I know the clinic timing is quite tight. I spoke with Pek about this as well. But because we are already doing the post-COVID clinics, I think we can sort of have some idea of how we can run the post-ICU clinic as well. Yeah.
Okay, thanks for the ideas. That's something that we are hoping to start. Also, beginning with the post-COVID clinic. There's a question actually, a couple of questions. Yep. Can you click?
I just click on the Q&A. Okay, I'll just read out the first question. How should we deal with the weekend dips in the rehabilitation efforts? Okay, that's okay. And the second question is by Prof. Tungkusara. Shouldn't it be the rehab team who run the clinic, or would it be combined with the intensivist? And the third question is by Prof. Julia. What about ICU family support group? Any possible role?
Yeah, I think probably to address Prof. Tungkusara's questions, I think it should be a combined clinic.
Yes.
Intensivist and the rehab team. And maybe Craig, you want to comment on the weekend dips?
Okay, I really have to address this as, of course, we in Malaysia, it is a service that we actually have to look into and actually improve further. Of course, we require all stakeholders to come in and rediscuss this. Yeah, definitely there is, but of course we actually have to discuss further and see how to go about this. Whereas the third question would be the
perhaps if we could train nurses to also be involved and actively.
So we talk a lot about disciplinary efforts. So usually it's about multidisciplinary, but multidisciplinary, basically the concept is just that every party is doing their own thing. Interdisciplinary, well, they come together and discuss some things, but we actually have to go forward and look towards this concept called transdisciplinary, which certain other countries are doing because addressing the lack of manpower. Other teams could actually step in and not say have overlapping, but actually fill in their role. For example, like in UK, where they actually have so many physiotherapists. I remember Dr. Shivani saying that there's actually for every 2 patients, there's 1. But however, in Malaysia, probably we do not enjoy this luxury. But we do actually have our staff nurses to come along with this. To help out. So as long as we actually could train the staff nurses, and especially in the simple cases, and we actually have our therapists to monitor and supervise the more complicated cases, I think we probably could shore up that gap. Yeah, but of course, this requires requires further training and a lot of team effort as well.
It's almost 9 now, or already 9. Just maybe Shivani, you want to respond to Julia's question? What about ICU family support group?
Yeah, in an ideal world, that would be great. Yeah, but I think we should start with the post-intensive care clinic first. Yeah, get the patients and the family in, and then once we get the numbers, then we can start a support group. We can sort of let them lead the way once we sort of stabilize them and they can support each other. Support groups are fantastic. Yeah, it's always lovely for patients to be able to open up to each other compared to being open to a person who's not undergone what they've gone through. Yeah, so we do have support groups for our spinal care, our TBIs, and a lot of other neurodegenerative disorders as well. But ICU is something to start. Yeah.
Okay, so we have to conclude the session. It's been a fantastic session. Very enlightening, a lot of strong take-home messages, and I hope with all this we could now approach our practice with a new and fresh perspective. And I would like to thank again our 2 speakers, Shivani and Pek, for the engaging deliveries. Thank you, everyone, and till then, may the rest of your day be good and productive. Thank you.
Thank you.
Thank you. Thanks.